Christy Cahill. I'm the Executive Director of the Colorado Cancer Coalition. I want to welcome you all to the second annual Colorado Collaborative on Lung Cancer Screening. And when we initially intended this 2 years ago, it was going to be in person, and we're now on our second version of virtual. So thank you all for sticking with us and joining us for our second annual virtual symposium. And I'm doing this for Debbie because she's going to lose her voice. So we are saving her voice for her presentation. Oops. Excuse me, sorry. So in a state where 23 people die a day from cancer, and in the state where cancer is the leading cause of death, and most of you probably know this, that lung cancer is the leading cause of cancer death, how do we work together to prevent cancer, find it earlier, treat it better, and improve the quality of life for survivors? You are a big piece of that puzzle by engaging in this work and coming here and networking and sharing best practices and just being a piece in the cancer prevention and control is huge to have you here at the table. Oops, sorry. And then the coalition acts as that convener, and the Lung Cancer Task Force acts as that convener to provide education, networking, best practice sharing, and partnership opportunities for those working in oncology care and support. And in addition to what we provide for people that work in oncology, we also have resources on our website for patients and caregivers to find the resources they need when they need them. And my mouse is very finicky today. Here's our agenda for the day. We're gonna have Debbie review the USPSTF recommendations, and then every year we've been getting all payer claims data, and so Dr. Jim Fenton will review that, and then we're gonna go into a breakout with an interactive Jamboard where you can add virtual sticky notes, and we're going to talk about your biggest successes and challenges in lung cancer screening. We'll have a short break and then come back to recap from the breakout sessions, and then we'll have the second half talking about challenges and barriers in lung cancer screening, and we'll talk about adherence to annual screening. Aaron Hirsch will cover that. We'll talk about financial issues. And then we'll have two panels at the end. One is a panel discussion with navigators, and then a panel, I'm thinking ahead to the next week. We'll have one panel at the end with the navigators. And then we'll wrap up. And so just before we get started, I want to thank the University of Colorado Cancer Center for being a supporter of the symposium, as well as AstraZeneca. And just a few little logistics so that people can find you on chat. Please be sure to rename yourself, and you can add your pronouns if you would like, or add your organization. And then there's a chat function, so if you have questions, you can put your questions into the chat box, and we'll be sure to bring those up at the appropriate time. And for the most part, please keep yourself muted so that we don't get background noise unless you want to come off to ask a question when it's time for that. And then please, especially during the breakout sessions, turn on your camera to engage and so we can feel more face-to-face. And then just a reminder as we're getting started today that we have another session on the 12th with some networking beforehand, and then the symposium session after. And at the end of today too, and throughout, I'll be putting in a link to the evaluation. So please, at the end, fill in our evaluation for today so we can better meet your needs for the future. So I'm going to stop my share now and turn it over to Debbie.
Okay, hello, and I'm going to try to share my screen with you all here. And can you all see that?
Yep.
All right, is it full screen? Whoops, wait a minute. Here it is. Okay, First, I apologize in advance. My voice is a little raspy. It's better than yesterday when I had no voice. But I'm delighted to be with you today and to share with you some really valuable and important information about lung cancer screening, some positive information. And as most of you know, we did get some new U.S. Preventive Services Task Force recommendations last March. So I'll talk about those and then provide a little bit. Yeah.
Your screen sharing actually went away.
Uh-oh. All right. We'll try this again.
There we go.
Okay. We're going to just talk about some eligibility criteria, information, and insurance coverage. I have some disclosures, and then just as objectives, we will talk about the benefits of these new recommendations, the timeline for implementation, and then some important information about reopening the Medicare NCD. So this was the really good news we got last March. And the U.S. Preventive Services Task Force released new recommendations. And importantly, they lowered the age to start screening to age 50, and they lowered the cigarette smoking history to 20. And then they kept the 15 years since quit, or you had to be a current person who smoked, and you couldn't have any signs or symptoms of lung cancer. We were still given a grade B, and I'll talk about that a little bit more. There is a really nice summary of the recommendation that was published in JAMA that same day, March 9th, 2021, if you want to search on that and read to your heart's delight. The task force review process was robust. They reviewed 223 publications, 7 randomized control trial articles, and that involved over 86,000 patients. It is important to note that the National Lung Screening Trial in the US and the Nlst trial in the Netherlands were the only adequately powered randomized control trials. And if we do a little look back, we've come quite a ways. So back in 1996, there really was no recommendation for lung cancer screening. In 2004, it was determined by the task force that there was insufficient evidence. And in that time, really all that was available was chest x-ray and sputum cytology. Then in 2013, after the results of the National Lung Screening Trial were released, then it was recommended by the task force that eligible patients get screened. And at that time, the eligible patients were age 55 to 80 with at least a 30 pack year history of smoking and the grade B recommendation. So what was good is that then lung cancer screening was covered as a preventive service because of the Affordable Care Act. Now, in our new recommendations, as I mentioned, the starting age was dropped to age 50, the smoking history, a minimum of 20 pack years. It did keep in place an upper age limit of 80 and kept in place that a patient had to be either currently smoking or be within 15 years since quitting. And this was referred to as the 50-80-20-15 plan. So the benefits of this strategy is that the drop in age and pack years are supposed to help address the disparities in lung cancer screening. And I think they do. They may not go far enough, and there's been some criticism there, but at least it's a start. So the 50-80-20-15 strategy will increase the relative percentage of persons eligible by 87%. And in particular, will address the racial disparities, particularly in Blacks and Hispanics, with a relative increase in eligibility of 177% and 112%. So some folks have asked, why did we get a grade B? Well, it was determined that there was moderate certainty that annual screening for lung cancer with low-dose CT has a moderate net benefit to persons at high risk of lung cancer. And to get a grade A recommendation, there has to be high certainty that the net benefit is substantial. Now, you could argue that there may be high certainty and we think the net benefit is substantial, but the review done by the task force did not determine that. What did they base their information on? I think it is valuable to look at a couple of papers that were published since the original task force recommendations in 2013. And there was a really valuable study published by Aldrich in JAMA Oncology in 2019. And this study evaluated the diagnostic accuracy of the task force criteria. Now, these were the 2013 criteria in a predominantly African-American population and a low-income group. And the results showed that African-American ever smokers were at higher risk of lung cancer than white ever smokers, and that a smaller percentage of African-Americans met the task force criteria than whites. And part of the reason is they found that African-Americans get lung cancer at earlier ages and at a lower pack year history of smoking. There was also some data showing that women got lung cancer at an earlier age and a lower history of smoking. So it was then recommended that we revisit the evidence and the recommendations for lung cancer screening. And this bar graph, I think, shows very nicely how cancers were distributed among the different racial groups and looking at the pack year history. And you can see in orange that the majority of the African-American population had much lower exposure than the white population, which is in gray. And so this was certainly taken into account then with the newer recommendations from the task force. And then looking at the 2013 recommendations then on the left with the recommendations that were originally proposed and then provided in March, it does narrow the gap. And we think it does help address some of the racial disparities. There was another important paper by Pasquinelli that looked at risk prediction models versus the task force criteria recommendations at the time. And the risk models look at a total of other risk factors and looks at different ages of patients getting cancer and the smoking history and so forth. And this paper found that 23% of African Americans would have qualified for lung cancer screening through a risk prediction model that wouldn't have otherwise qualified. And that African Americans were ineligible by the task force criteria because they quit smoking greater than 15 years ago, that 49% of the African Americans then wouldn't have qualified. And then of those that were ineligible because their smoking history was less than 30 pack years, 40% more would qualify. So this really was additional evidence that we needed to revisit, reevaluate what we were considering for risk prediction, and that's what the task force did. So the good news is that we are bringing more people into screening. And with the Affordable Care Act, commercial insurance and state Medicaid programs in expansion states, and Colorado is one, are then required to cover these new criteria and with no pay or cost sharing by the patient. Now, commercial insurance and providers have up to 1 year from the start of their next year plan to implement the new criteria. But the good news is that nearly all commercial insurance payers have adopted the new recommendations. There's only one plan that hasn't. And then until the new coverage is in place, we will have to advocate for those patients and try to get them screened. The good news about Colorado Medicaid is they adopted the new recommendations immediately and in fact backdated them to January 1 of 2021. Medicare has reopened its NCD, and this is really significant. They are doing their own review of the eligibility criteria and the evidence, and we anticipate that they will be giving us some draft recommendations for their coverage very soon. So what can we do now? If there are commercial providers that you encounter that have not adopted the new recommendations, then try to educate them and tell them that most everybody has. And those radiology benefit managers may be willing to listen to you. And we also have a letter template with information that you can send to them. And I'm going to be sharing with you some information about that. We can also ask patients to advocate for themselves. And then if all else fails and insurance denies a patient that is, let's say, 52 and 20 pack years, then we can offer those patients a self-pay option. The American College of Radiology, along with the Society for Thoracic Surgeons and the GO2 Foundation, did send a letter to the major insurers early on, and I think this did help to have most of the insurers come on board. There is a copy of that letter that was sent, a template of that letter, I should say, that you could use if you want to communicate with your insurance providers. And that is on the website for the American College of Radiology, and I'm going to give you that website information later if you want to have a copy of this template. Other good news is the American Academy of Family Practice did update their guideline in March, and they have also considered lung cancer screening CT now a recommended service for their eligible patients, and they gave it a grade B as well. So with Medicare reopening their coverage, everything is literally on the table. They reopened their decision on May 17th, and they accepted comments until mid-June. Our lung cancer task force did send comments, as did a multitude of organizations around the country. And then we were fortunate that the American College of Radiology, the Society of Thoracic Surgeons, and the GO2 Foundation were able to meet with the CMS Coverage Advisory Group virtually in the beginning of August. And we did discuss that we certainly hope that they will align with the new recommendations, but also consider doing other things that may decrease the complex eligibility requirements that Medicare now places. We hope to see a new NCD maybe by January. Other recommendations were continue to screen on an annual basis, to use age and smoking history to determine eligibility rather than elaborate risk prediction models, that all current smokers enrolled in screening should receive smoking cessation interventions, that shared decision-making is important, and that the LungRad's structured reporting is valuable in providing guidance on follow-up. So for further information, you can go to the acr.org Lung Resources page. You can also feel free to contact me. I'd be very happy to take any questions or emails from you. So I thank you for your time, and we will take questions if we have time. No, we don't right now. So we're going to, oh, we do. We have 5 minutes for questions. Well, how about that? So I can take some questions. I don't see anything in the chat box. Let me stop sharing. And what might be in the chat box? Is there any question at the moment?
I just provided the link to the resource that you just gave.
Okay.
I don't see any questions yet.
All right. Well, what we could do then is we can move on and we can have Dr. Fenton present his information on the data that we get in Colorado from our all-payer claims database. So Jim, I'll hand it off to you. And Jim is one of my colleagues. He is a pulmonologist with National Jewish Health that works down by the Swedish hospital and works with their lung cancer screening program. And he's also co-chair of our lung cancer task force.
Great. Thank you very much, Debbie. I'm really happy to be here and appreciate the invitation. Yeah, it's been great to work with the Colorado Cancer Coalition with everybody. So I'm going to talk a little bit today about our database that we've been using. So Christy, should I just go ahead and do the share now?
Yes, you should be able to share now.
Do that. And we'll do the slideshow. Can you see that?
We do not see it yet.
All right. Let's do that. Can you see that now?
Nope.
All right, hold on a second.
There we go.
You got that?
Yep, just change into presentation mode and we're good to go.
Okay, how's that? Can you see it?
Yep.
All right, great. Thank you, everybody. I'm glad to be here. We're going to talk a little bit about claims-based reporting of lung cancer screenings really in the last 5 years. I am, as Debbie said, part of National Jewish Health. I do work at Swedish. I'm a pulmonologist and work a lot in lung cancer, director of the lung cancer program at Swedish. I have no disclosures. As everybody knows, this month is Lung Cancer Awareness Month. That's why we're all here. And it's good to see everybody together focusing in on a very important topic. So we know the importance of lung cancer. About every 2.5 minutes, someone in the United States is diagnosed with lung cancer, and four in five of those patients will die of the disease. As mentioned earlier, lung cancer is the leading cause of death in both men and women. Remember that it's not lung cancer. It's not breast cancer or colon cancer. It's actually lung cancer. And although we've done better with our survival rates in the last 5 years, still over 220,000 people will be diagnosed with lung cancer this year. So screening is important. We know that if we can detect lung cancer early, then we have a much better chance at a long-term survival. We know that if lung cancer is detected at stage 1, there can be an 80% chance of a 5-year survival. Even many of the patients can be cured. So if it's detected later stages, as you can imagine, the rate of 5-year survival is much lower, less than 20%. The American Lung Association estimates that if we do lung cancer screening, if we can determine and detect lung cancer early, some 48,000 lives could be saved. So that's been the focus of our lung cancer screening task force, lung cancer task force in general. Unfortunately, the screening rates in Colorado are still not very good. In fact, really in the lower tier of all the states in the nation. Massachusetts, New Hampshire, and Vermont have some of the highest rates of lung cancer, but still only about 15%. Colorado, unfortunately, is down below 5%, below the national average in number of lung cancer screenings performed. So we're hoping, all of us hoping to change that a little bit with some of the seminars and the education that we've been doing. We want to detect lung cancer when it's small like this, not when it's too late like that. So the Colorado Cancer Coalition, the Lung Cancer Task Force, utilized a database that we were able to access really fortunate to be in Colorado. We're one of 18 states that have access to an all-payer claims database that provides information on lung cancer screening, really all claims. In general, talk a little bit about all-payer claims databases. Not too many people are familiar with them. I certainly wasn't. But they're large state databases that include medical claims, pharmacy claims, dental claims, and they're information that's collected from both private and public payers. It's data that's reported directly to the state, usually as a part of a state mandate to report that data. And the data is produced based on price, resource use, quality, and provides quality information to consumers. For our database in Colorado, the Colorado All-Payer Claims Database, about 75%, so 3/4 of all insured Coloradoans are a part of that database. So that means commercial insurance, but also Medicare Advantage, Medicare, and Medicaid. So that other 25% of Coloradans that are not covered would be self-pay, TRICARE, VA, those types of things. So they're not included in the database, but the very robust and provides a lot of information for us. And we'll talk a little bit about what we were able to see here in just a second. These databases really have a number of advantages over other types of databases because they do provide information from private insurance carriers that many other data sets do not. So most or all insurance companies operating in that state have to report in that database. And also provides information on patients across care sites. So even if they're in the hospital or in the emergency department, we get all that data, we get all that information. This is a map of the United States showing the states that do have a database, the all-payer claims database. The dark blue is the states that have existing databases that you can access. Colorado is actually highlighted here, but is only one of 8 that has an active accessible database. So we're lucky to have that. If you want to find out a little bit more about all payer claims databases and what's available and what they are, the Agency for Healthcare Research and Quality website is very helpful. So in Colorado, our database is administered by Civic. Civic is a nonprofit, nonpartisan organization that was founded about 11 years ago from a mandate from HCPF, the Colorado Department of Healthcare Policy and Financing. And it was actually launched in 2012 and with the aim of providing better health, better care, and lowering costs through an analysis of data. This is a screenshot of the Colorado All-Payer Claims Database through Civic. You can go on the website, websites listed below, civic.org, and you can hit any of these tabs on the top part and then put in what your instructions are on the side here. This is just an example. This is all of Colorado, although you can put in different counties and get data by county. So this just shows the number of insured people that the Colorado All-Payer Claims Database reports out information on. So in this case, in this query, 60% of the total population had claims. And then if you go to a different tab, you can put in different insurers, different years, and get a lot of data and later information just on this dashboard that's provided to everyone by Civic. Now, Civic does charge for their service. If you want specific information out of the database, then we're able to defray some of the cost with the grant funding from the health department and other sources. So we were fortunate to get that grant for the data collection. So what is some of the data that's actually collected? Well, it's of course encrypted data, but it talks about patient demographics. We're able to determine diagnoses, procedural codes, drug codes. We get information on the service providers, the prescribing physicians, their healthcare plans, where the studies were performed, things like that. So it's a rich set of data that all of us really potentially could have access to. And we found it very helpful in our efforts to increase awareness and information on lung cancer screening. So we asked Civic to give us information specifically on lung cancer screening, and what provide CPT codes to them and provide questions that we wanted answered. So I want to go through this a little bit because this has changed over the years, but we asked Civic to query the low-dose CT screen, the CPT code G0297 and G0296, which is the counseling visits. Before that, there was an S code, which is a screening code that went out of date, actually really just was used in 2015. Just to be clear, and Debbie will make sure that if you're ordering lung cancer screening CAT scans now, you need to use the permanent CPT code, which was effective this year, 71271. So use that screening CT code, not the G codes. But for our query, for our database, we were using the G codes. We asked Civic to answer a number of questions. We wanted to know the number of lung cancer screening services performed. We wanted to know the demographics on the patients. We wanted to know who was providing the counseling services, where the studies were being done, what imaging centers, what insurances were paying for that, and then if there was any coverage issues. And then finally, the database is able to query all sorts of diagnostic codes. And so we also wanted to know, were there active lung cancer diagnoses found after the lung cancer screening studies were performed, and then other co-conditions. So this is the data that we were able to achieve, and it's up to 2015 to 2020. As you can see, there has been a year-over-year increase in the total number of screening services performed, except with 2020, when we all know kind of what happened with COVID. So that all screening services, even a lot of cancer services, were reduced, obviously, due to COVID. So we also looked at the lung cancer screening shared decision-making visits, how many of those were billed, and this is all billed or performed. And as you can see, let's take 2019, you can see that there was 612 shared decision-making visits billed during that 2019 year. Well, there were 10,000 studies performed in 2019. So the uptake and the utilization of shared decision-making was very, very low. And that's one of the things we hope to shed some light on, particularly with this data. Other things that we were able to show were, basically the age demographics. The 65 to 69 year age group was, the largest number of scans were performed in that age group. And then the number of scans fell off on either side. Notice that age 50 to 54 and age 80 and above, those are not a part, or at least were not a part of the recommendations between 2015 and 2020. Those are outside, those are scans done outside of the U.S. Preventive Service Task Force recommendation for age limits. Some other data we were able to achieve by the querying the database includes just looking at lung cancer scans by gender. Remember, women and men are almost equally affected by lung cancer now, and both pretty much the same number of men and women are getting screened. We can also look at where the patients live. So the database is able to pull the 3-digit prefix of the zip code. They don't provide the whole zip code, but the 3-digit prefix for the zip code from the patient's home zip code. And as you can see, most of the studies were done in the Front Range in the Denver metro area, including Longmont and northern suburbs, also in Colorado Springs. And then we were also able to look outside the Front Range at some of the communities outside the Front Range, and they may be areas that we could help increase the uptake of lung cancer screenings in the future. Salida and others. The database also gave us information on who is providing the counseling services. Generally, it's done by APPs, physician's assistants, nurse practitioners, generally working in internal medicine, pulmonary, and family medicine. But they may also be working for an acute care hospital like National Jewish that has an integrated lung cancer screening program, where the hospital and the staff of the hospital, the APPs particularly, provide the lung cancer screening counseling, and then also provide the scans. We were able to get information on who was actually performing the studies. As I mentioned, National Jewish is doing a lot of the scans in the state, but Denver Health, University of Colorado, Centura, Health One, Envision, and others. So a lot of data as to who is actually providing the scans themselves. And then we wanted to look at insurance coverage. Remember that, as Debbie said, lung cancer screening is covered by commercial payers, Medicaid, Medicare, and Medicare Advantage. At least most states cover lung cancer screening in their Medicaid programs. And most recently, the pre-authorization for Medicaid was dropped here in Colorado, thanks to Dr. Dyer's work on that. And the payer coverage type, as mentioned, about a quarter is commercial, and the rest is either Medicare, Medicaid, or Medicare Advantage. One of the things that was interesting, I mentioned earlier, was about the diagnostic codes that are seen in addition to the screening, lung cancer screening services. And one of the things that you might imagine, the diseases of the respiratory system and diseases of the circulatory system were often listed in addition to the lung cancer screening, but also mental health and behavioral disorders were very high on the list. And that may represent an opportunity for us to reach out to the behavioral health providers and see if we can elicit their help in doing lung cancer screening. So how do we interpret this data? And we'll talk a little bit about that. We have seen that year over year, there has been an increase in the uptake of low-dose CT scans for lung cancer screening at all age groups, really. But unfortunately, the total number of lung cancer screens is low compared to the eligible patients. We still have a lot of work to do. Urban centers are probably responsible for most of the screens. There are areas that were identified in the database that had low uptake, and maybe we can reduce some of those barriers in rural regions of the state. And then lastly, again, just to emphasize, shared decision-making visits are mandated by CMS, not by all insurance, but by CMS, not yet performed. To my knowledge, there's not been audits yet, but they should be at least one shared decision-making visit per lung cancer screen, at least initially. So we hope that this database that we've been using in the Colorado Cancer Coalition, the Lung Cancer Task Force, the database can be helpful to help market lung cancer screening to the general population. We think it's going to be helpful to enact legislation and industries change. As I mentioned, Dr. Dyer already helped eliminate the pre-authorization for Medicaid. And we hope that the database can help reduce or at least identify barriers to screening and help us to increase screening rates throughout the state, especially maybe in rural areas, and maybe even with using our mental health providers. So in conclusion, the all-payer claims database that's available in Colorado, available to all of us, can provide valuable information to direct the public health education efforts in hopes of increasing lung cancer screening. Again, we're lucky to be one of the states that have a complete database to query and access. So that's really a quick overview on what the database is and how we've been using it. Hopefully that'll increase the number of screenings over time here. So again, more information from Civic, also more information from the AHRQ website here. So I'm available, happy to answer questions. If not, so now we do have the breakout session coming up, and I will stop sharing my screen there. Sorry, my video went out. It's been acting up a little bit, but I hope everybody could hear me anyway. So.
Thanks so much, Jim. That was wonderful. And as Jim stated, I think we're just very fortunate to be able to access that data in Colorado. Many states use the behavioral health survey to get their data, but that's self-reported data. And I think even if we had that, it's valuable to have this kind of really hard, solid, objective data for us to use. We will eventually in Colorado get the behavioral health survey to ask questions about lung cancer screening CT. I think that's in the works. Yeah. So thank you, Jim. And there is one question that I can answer maybe before we go to the breakout. Oops, I lost the chat. I think the question was whether CMS was going to consider extending the upper age limit to 80 or over 80. We did discuss that with them when we met. We just said that, you know, if you want to argue against ageism, you really ought to be evaluating an individual on their own merits. And some 81-year-olds are healthier than some 60-year-olds. And so in general, our recommendation was to eliminate the upper age limit and just be it determined on an individual basis by the provider if the patient should get lung cancer screening. So we'll see. We're going to have to see what Medicare decides. Okay, well, I'm going to hand it back to Christy, who's going to give us all the instructions on the breakout rooms.
Yes.
Great. Thank you.
And then the other was the problems with the current problems right now, that there's non-uniformity in the eligibility and coverage since with the new criteria from the task force, U.S. Preventive Services Task Force, we've got the lower age limit and smoking history, but of course we don't have Medicare on board yet. And then not all commercial insurance have adopted the new coverage criteria. So it is a challenge. It is an absolute challenge for the folks that are navigating and scheduling and trying to figure out who's eligible. The other area that was identified as a problem is the whole billing and coding. And I'm going to be talking a little bit about that later this afternoon. Maybe it'll provide some help, but there can be a situation where a patient may end up with a bill when they shouldn't, and there can be a denial afterwards for, you know, even if they've authorized. So it can be challenging. And so, as somebody said, there's a lot of one-offs. And it seems like that a lot of the folks that are really coordinating these programs and serving as navigators are sort of constantly putting out little fires. So those were some of the challenges we discussed.
Great. Thank you. Jim, I think you were group 2.
We were group 2, yes. Can you hear me?
Yes.
Okay, great. So yeah, I think we tried to, I got sticky note happy here a little bit, which is okay. Nicholas helped to outline some of the challenges were just still the stigma. And I think Jamie talks a lot about that. Some of either patients not wanting to get screened, not really wanting to know the diagnosis, and maybe even stigma from providers saying, well, we're not going to be able to find anything we can do anything about. And one of the suggestions was that we should start a little earlier in terms, now that we are screening at age 50. If you have a smoker prior to that, you can say, okay, remember at age 50, you're going to need to be getting your screening CT scan. So getting the word out early. Somebody also mentioned telehealth that was helpful at doing outreach, but also shared decision-making visits. So access to care. So stigma and access, both patient and provider awareness were barriers. Again, getting the word out. Patients need to advocate for themselves, be their own advocate as best as possible. That was a barrier, they're just not. And then one of the things that came up was trying to get, maybe I should put this down here, but get community leaders really interested in lung cancer and lung cancer screening so that they can advocate for their at-risk populations, particularly in populations of patients of color and at lower socioeconomic groups. So some of the things that we think that could be successful or successes could be doing, getting our community leaders involved so that they can help advocate to do some public awareness campaigns. I think that I see public awareness campaigns for a lot of different medical issues, but and smoking actually, but not necessarily lung cancer screening. I think one of the things that would help the providers would be flags or reminders in the EMR that could be of help. And I think that's particularly true in Kaiser system. They have a very integrated system that's helped them be at the forefront of lung cancer screening. And then finally, lung nodule programs can also be helpful in or some of the successes that we're seeing an increase in screening because of awareness through the lung nodule program. So kind of things that what we talked about in our session here. So
great, thank you. Group 3, it was Morgan.
Thanks, Christy. Hey, everybody. So for our group, one of the biggest challenges that we talked about, there are a few here, but one was until recently, the lack of support or buy-in from primary care and family practice providers. And this is changing. We agreed that the new preventative service task force guidelines have definitely helped with, I guess, promoting lung cancer screening a little bit more and making it kind of at the forefront, or at least more of a priority. But we also acknowledge that, primary care providers are still really busy. There's a lot of competing priorities there. And it's just something that they don't always get to. And I think part of that, we've talked about this in previous talks and other events about, is the grade B recommendation. And that's something that does impact things. Another item that came up was this concept of shared decision making and kind of the difficulty to that, or of including that. So some do see that as a burden when it comes to lung cancer screening. And I made the point that there is still a lot of variability with what constitutes shared decision making. I know that we have, a pretty detailed idea of what that looks like. But when it comes down to practice, sometimes a physician will ask something as simple as, do you want to get scanned? And that's considered the shared decision making, and we all know that it's a much more nuanced conversation that requires more thought and discussion. So there's that. And then to follow up, one other challenge, this is similar to what Debbie was saying in group one. One of our breakout group members did bring up the concept of adherence and making sure that patients show up for their scan every year. We really don't have a good way in the state of Colorado, from my understanding, of tracking patients who move from one facility to another. And that if they, get scanned at place A, maybe move to elsewhere in the state and get scanned at place B, there is some difficulty with, tracking that follow-up. So that might be something that the task force could work on, Debbie and Jim. I don't know.
Point.
But that's all we had. Christy, sorry.
Sorry, I didn't want to. Sorry, my internet I think is going unstable too. Erin, you were the last group for this one?
Right, group 4, and mostly what we talked about, I think, echoes some other areas that people have found is being challenging, mostly, lack of awareness, and how can we raise awareness, not only in the medical community, but also just in the general population. I know Jamie likes to talk about someday we hope that lung cancer screening with low-dose CT will be just as well known as mammography. So I think that's something to aim for, but we definitely need some more awareness around not only that lung cancer screening exists, but the eligibility for it. And then we also did have a lot of discussion about how problematic tracking is. And then if we're having difficulty tracking, that's going to feed into getting people to come back and be adherent for both the annual scans, but also the shorter term follow-up if needed. And we talked about how sometimes like the nurse practitioners or PAs forget to put in an order and then it's not flagged. So that person isn't tracked properly. So I think last year in the symposium, we talked about a team-based approach. And I think that's, a good thing to remember is that we really need an entire, every clinic, all our clinic staff, our directors, everybody to kind of be involved in our processes. I think that was the two major things that we discussed.
Great, thank you all. Now we have 10 minutes left to talk about the successes. So Debbie, back to you to go through the successes from your group.
Yeah, so there were some. One of the first things that was commented on is implementing a software program really helps in managing and tracking patients. So I think that the navigators and coordinators really appreciate having something other than an Excel spreadsheet. The other, of course, the software programs also help with reminder letters and so forth. It's certainly a success to find out that you have found an early stage lung cancer. It's also a success when you feel like a patient has decided to quit smoking based on their lung cancer screening experience. It may not even be a cancer, but it may be other findings on their CT, or just the whole idea of talking about the importance of quitting smoking. We also were fortunate, Elizabeth was in our group, and she shared with us about several of the resources that AstraZeneca is developing to educate providers, and also particularly on smoking cessation. And then in general, just the lung nodule programs that deal with not just screening, but incidental nodules. You can certainly find many cancers that way. And then some programs had success visiting provider offices that they would definitely notice an uptick in referrals after they'd been out to visit a particular physician group office, and those people can be some of your champions. So I think that was our list.
All right. Dr. Fenton, up to you now.
Yeah, hi. I'm sorry, I think I went over a little bit of the successes with the first overview, but you know, one of the things that I find is just try to tell patients that they should get the lung cancer screening CT scan in conjunction with their mammogram if they're due for that. Or I counsel men and say, just like your wife gets a mammogram, you should get your CT screening. I agree that having some type of electronic help to remind providers is good. Like I said, EMR flags or EMR reminders have been helpful. And for us, probably the coordinated lung nodule program has really kind of increased awareness of screening. So those things are the ones that have really helped. I might ask a question to Debbie, though, if that's okay. Do you think that having—
Hi, Debbie.
Hi, Debbie.
Hi.
A centralized program helps? Because the reason I bring that up is because we have a decentralized program, you know, basically provider run.
I can't hear the symposium.
Oh, somebody's having a hard time.
Okay.
Go ahead, Jim.
I'll try to work on that.
But you have so anyway, one of the successes might be a centralized program. And so I'll just leave it at that.
I think there have been even papers written about centralized programs do have in better compliance with annual screening or follow-up. But I know it's not possible for everybody to have a centralized program. And some places actually do a hybrid approach that helps. So, you know, I think whatever you can do, you do. But there is an advantage that at least a centralized program, you have a little tighter communication, if nothing else.
Yeah. Okay, thank you.
Okay, ready to move on to Morgan's group 3?
Yeah, Morgan.
Sure. Thanks, everyone, again. So I think one of the biggest things that we honed in on was the updated guidelines and how that success on a macro scale kind of trickles down to smaller programs and state-run initiatives like what we're doing in Colorado. We talked about the guidelines and how payers interpret these, and how really the business model for a lot of payers, the way that their revenue structures are created is that it doesn't really always focus on these preventative health screenings like lung cancer screening, like colon, et cetera. So, I mean, we think the fact that the payers so quickly jump to that and put that into part of their plans, we're really happy to see that. Another thing that we talked about was that in community oncology practices, there's been an expansion of services that those centers are often offering. So, you know, you might see lung cancer screening being offered at a community oncology practice. And, you know, we've talked about what does that look like, because what does that look like for the patient experience? And we thought that was a success in that, you know, for breast cancer survivors or colon cancer survivors, if they have any of those risk factors that make them eligible for lung cancer screening, often we might miss out on that, or we're really focused on, you know, making sure there's not a recurrence of that breast cancer or colon, et cetera. So being able to look at the whole patient, we thought is another, you know, evolving trend in the screening space, and something we think is a success.
Great, thank you. After I just got you spotlighted when you were finishing, I'm trying to spotlight the speaker so you stand out. Erin, let's move to you and your group 4.
Okay. So in group 4, we talked a little bit about lung cancer screening grants and how there is more kind of attention being put on lung cancer screening and more opportunities for grants now for federally qualified healthcare centers, community programs to hopefully increase screening. We talked a little bit about accessibility, and that was from Grant at National Jewish, and they've had the opportunity to work with some more community type clinics and offer screening to people that are homeless or some other populations that may not otherwise be eligible for screening. So just making screening a little more accessible to more people. And then also we talked about, obviously, finding more early stage cancers is definitely a success. And Allie had suggested, maybe more attention needs to be paid to the percentages of early stage cancers that are being found by screening programs for some of awareness campaigns. I really like that idea. So, and that covered our successes.
Well, I'm going to jump in and just say thank you all for participating in this. I think, it was good to sort of see where you all are and some of the thoughts that you're having about, what are the challenges and, what do we need to be working on, but also to celebrate some of those successes. So this is a great lead in to Erin, because I know several of our groups did talk about the adherence to annual screening as being a problem. And we're so fortunate to have Erin Hirsch here in Colorado, a researcher at the University of Colorado. She dives very deeply into lung cancer screening and some of those important factors that help patients stick with it. So Erin, take it away. We're really interested to hear from you today about how to increase adherence.
Can everybody see my screen okay? We're good?
Yes.
Okay. So thank you, Debbie. As Debbie said, I have done lung cancer screening research for about 5 years, but my particular topic of interest has been adherence to annual lung cancer screening. The topic of my PhD research is developing a set of reminder messages specifically for annual lung cancer screening. I don't have any disclosures or conflicts of interest to report. And for about the next 15 minutes, our objectives will be to describe the importance of adherence in the lung cancer screening algorithm, to examine the problem of annual adherence and why real-world rates do not match those of clinical trials, and then third, to introduce some best practices to engage our lung cancer screening eligible population to improve adherence. First, I want to place adherence in the overall screening algorithm and why it plays such a vital part. I think we're all aware of the many pieces of our baseline screening scan. We need to confirm eligibility. We need to make sure shared decision making is documented, and smoking cessation resources need to be offered if applicable. But our process does not end here. We will get results and they will have follow-up, and this is really where adherence becomes a vital part of this screening algorithm. And there's kind of 2 buckets to adherence. Annual adherence, and this is what we talk about and what I'm going to focus on today, but this is adherence to our annual lung cancer screening CTs. It accounts for approximately 90% of baseline scans. The other 10% of scans are accounted for by this interval adherence component. These are people that will have shorter term follow-up because they have a finding that is more worrisome for lung cancer. And I just want to briefly mention there's this third type of adherence called baseline adherence. This is kind of the no-show rate to the baseline CT. There's very little data on this. So the effect on our screening process and algorithm is currently unknown. But low adherence to any of these components is going to be detrimental to the individual and population benefits of lung cancer screening. Say a little bit about why superior adherence has helped move lung cancer screening from clinical trial to real world clinical practice. Debbie talked a little bit about our evidence base for lung cancer screening comes from 2 large trials, the National Lung Screening Trial and the Nelson Trial. These graphs show the number of stage 1 lung cancers that were diagnosed at each screening round in these 2 trials. The Nlst is on the left, the Nelson trial is on the right. In the Nlst, 58% of stage 1 lung cancers were diagnosed in these screening follow-up screening rounds, and they had an impressive 95% adherence to 3 screening rounds. Very similar story in the Nelson trial. 73% of stage 1 lung cancers were diagnosed in follow-up screening, and again, they had a very good adherence at 90%. Therefore, efficacy of screening is highly dependent on adherence to these follow-up rounds of screening. Real world adherence, we're not doing as well. This graph shows adherence rates for annual screening from published literature. And these represent academic, community, and military screening programs. Some programs are doing better than others, but none of them are really coming close to matching the Nelson and the Nlst adherence rates. And also importantly, all these rates are for 1 round of annual screening, not the multiple rounds seen in our clinical trials. So how did the Nlst achieve 95% adherence? They maintained regular contact with their study participants by mailing a questionnaire at every 6 months. If after 3 weeks, there was not a response from the mailed questionnaire, they were contacted by phone. All contact was completed by a research assistant at the site where they were enrolled into the trial. So this was a familiar name, a familiar voice to them. And if they still were not able to reach that person, they contacted relatives or the physician on record to verify either if possibly that participant had passed away, or try to obtain a phone number or an updated phone number or address. So moving adherence from clinical trial to real world has been burdensome. And again, we know this is a problem. The Nlst population has been critiqued to be younger and healthier than the majority of the US screening eligible population. Overall implementation of lung cancer screening has encountered a variety of obstacles. There's many components to the screening process, and there's just general lack of awareness of lung cancer screening and low dose CT. And third, recognizing the scope of adherence and recognizing there's kind of these different components and there might be different factors that affect why somebody's adherent or not adherent is different between this component has really lacked kind of research into uptake also. So now I'm going to go over a few best practice opportunities for communicating and engaging with our lung cancer screening eligible population. And again, a lot of what I'm talking about is still in the process of being, going through research. So there's a lot of work to be done in this area, and I don't really talk about tracking because we know that tracking is a problem still. And this is more about engagement and communication opportunities, and those fall into 2 buckets, kind of the use of interventions, which is done for other cancer screening modalities, and also person-centered engagement. So we understand the population that we want to engage and communicate with. Talk about the importance of reminders, some options for reminder intervention targeting and tailoring, and also some imagery considerations. So less than optimal rates of adherence is not unique to lung cancer screening. Reminders are recommended with strong evidence, and that's the highest rating by the Community Preventive Services Task Force for both breast cancer screening with mammography and colorectal cancer screening with fecal occlusive blood testing. And these ratings are supported by 2 meta-analyses, and any intervention, including these meta-analyses, has yielded consistent positive results. So that means any reminder intervention has increased adherence rates. For mammography, this has been increased by a median of amount of 14% and 11.5% for FOBT. Telephone reminders have done a better job than print, but I think the main thing we want to know here is that any communication, any reminder is better than no communication at all. And this has been shown to play a vital role in lung cancer screening adherence as well. Kind of my first study I ever did for lung cancer screening adherence was using the population at the University of Colorado Hospital. And we observed complete non-adherence in participants. I'm sorry, can everybody see my cat? Complete non-adherence in participants without documentation of a reminder. And again, what I'm going to talk about next is there's no reminders that are specifically targeted and have been developed with the lung cancer screening eligible population in mind. There has been a lot of research in the past 12 to 18 months trying to define populations or characteristics that are associated with more or less adherence. Understanding these characteristics gives us potential options for reminder, intervention, targeting, and tailoring. I think it's important to note that overwhelmingly studies do not separate interval and annual adherence in their analyses. They kind of group them all into one big bucket. Yes, they're adherent or they're not. And we need to think of these as separate components. So any of these characteristics that are in red text have been associated specifically with annual adherence. And I want to say a little bit about imagery considerations in our reminders, because this is one of the main points of my PhD research, is that, imagery matters. There's been some qualitative research from Ireland, actually, that has suggests that any kind of imagery, including lungs and cigarettes, are ineffective in informational campaigns. So this ad at the top is actually from the American Lung Association. It shows lungs made out of matches and then set on fire. I don't know about you, but I don't like this. This image just doesn't look very friendly. This is in contrast to this ad at the bottom, which was developed by focus groups for an informational campaign in Kentucky. And here we're setting a completely different mood. We're with our family and we're outside. So again, this is a component of my PhD research, and I'm excited to see, what we find with this. Moving on, and now I'm going to talk a little bit more about person-centered engagement. The importance of understanding who our lung cancer screening eligible population is and how to communicate with them. I will introduce the engaged approach to lung cancer screening, talk about optimizing shared decision-making for adherence, and then again, kind of understanding who we're serving and how best to communicate with them. The engaged approach to lung cancer screening is a person-centered approach to supporting implementation of high-quality lung cancer screening. And this was an approach that was developed by my PhD research mentor, Jamie Stutz, who I think was able to join. And this was also developed in collaboration with colleagues at the Moffitt Cancer Center and the Longevity Foundation. These are the 6 principles of the engaged approach to lung cancer screening. The real emphasis here is that we're putting our participant at the center of all of our communications with them. And the screening process is tailored kind of to their perspective. So we want to treat every contact or communication as a way to build trust with them and a way to convey the importance of adherence. Another important component is to establish a single point of contact for program questions or issues. And the real idea about this approach is that we are building trust again with our screening participants, so they will continue to be involved and continue to adhere to annual screenings. And talk a little bit about the importance of conveying the process of lung cancer screening in shared decision-making. Morgan talked a little bit about how there's some differing opinions and different ways on how shared decision-making is done, but we really need to get the message across that lung cancer screening is a process. It's not just a one-time test. Jamie and I do have some preliminary data that shows a claim for a shared decision-making consultation is associated with increased adherence. So again, this is just another place we could build engagement with these people and really try to improve adherence through communication and messaging. We want to remember that the lung cancer screening population is unique. They're different from populations that are eligible for other cancer screenings. They're stigmatized. They may be shamed for cigarette smoking. They may be fatalistic, meaning if they have a lung cancer diagnosis, they feel they deserve it, and there's nothing that can be done to change that. They're skeptical about doctors, about the healthcare system. They may be disengaged, again, because they've gone through many years of being stigmatized, being blamed, being shamed for cigarette smoking. And they're also dispersed. I think the main point here is that our screening eligible population usually has less access to care and is less likely to partake in preventive care, such as lung cancer screening. I have a little box here about engagement and outreach tips, and just in the interest of time, I'm going to mostly skip this. These tips are in a toolkit that Betsy Risendahl will be talking about next week, specifically about patient navigation in lung cancer screening. When I was putting together these slides, I really couldn't help thinking, with the strategies used by the NLST in their study, and the strategies or the principles of the engaged approach to lung cancer screening, I don't really think we're that far off. These 3 principles are something that every lung cancer screening program could do. Use every contact to engage with them about adherence, identify a single point of contact for questions, have somebody they know and they can be familiar with, and utilize all of our personnel to message adherence. We have a pretty good understanding of our target population. So if we can utilize these other 3 components of the engaged approach to lung cancer screening, we can start to build trust, reduce some stigma, and increase adherence. So in conclusion, mortality reduction seen in clinical trials is largely driven by superior adherence rates. Overall, real-world programs have failed to achieve half of these needed adherence rates. Therefore, the individual and population level benefits of lung cancer screening is presently unfulfilled, but we can communicate through reminders and other interventions, and this is showing to be imperative. We can start understanding our population, working to reduce stigma, which will also build trust and ultimately help improve both adherence and uptake. And I know I'm about a minute over, so if anybody has questions, please, feel free to drop those in the chat and I will respond.
Thank you so much, Erin. Wow, that was a lot of good information. And I think people probably will be begging for more. So I know Erin will follow up with anybody that maybe posts a question in the chat. So in the interest of time, I am going to go ahead with a presentation for you all on financial and economic issues related to lung cancer screening. So let me share my screen. Oop, that's my old presentation. Sorry. Okay, am I sharing yet?
Nope.
All right. Now, do you see something?
Yep.
All right. So one of the things that often comes up when I've been able to go out and talk with folks about lung cancer screening, and particularly some of the folks that are sort of on the front line and trying to navigate through all the issues of eligibility and coverage and so forth, is, questions specifically about these issues. I am going to provide an overview of this discussion today, and I'm also going to review some highlights of a handout that was created by the ACR and the National Lung Cancer Roundtable. It's an economics and billing quick reference guide on lung cancer screening, and it looks like this. And so I will be giving you the link to this, and I hope you will find it to be a useful resource. So I'm just taking a few highlights out of this document, but one of the things that comes up frequently is just kind of a question about the definitions when we're talking about CTs. And, in general, obviously, chest CT can encompass a lot of scanning done of the chest, and it includes a low-dose CT. It includes an interval chest CT. It includes a CTA that may be done for pulmonary embolism and so forth. So just think of the word chest CT as just a generic term, and it can be done with either a regular dose or a low dose. A low-dose CT is it's a CT using the low-dose technique. And it's required for lung cancer screening, but it's actually recommended for other chest CTs as well. And in particular, if you're doing a follow-up scan for a nodule found on a lung cancer screening CT, there's no reason that you would need to do a full-dose chest CT. You can use that low-dose technique, even though at that point it is now not a screening CT, it's in the world of the diagnostic CTs. So a diagnostic CT, or in our screening world, we think of this as an interval CT. It is a CT performed off cycle for diagnostic purposes. So it's not done for screening. It's to follow up maybe in 1 month or 3 months or 6 months, that screening CT. And as I mentioned, in most cases, it should be performed with that low dose technique. Now, there's another term that we use called a surveillance CT, and that is a diagnostic CT done for surveillance of patients with a known lung cancer. So most patients diagnosed with lung cancer and treated, either however they're treated, they go into a surveillance phase, and they typically get CTs every 6 months for usually about 5 years. And so the term we use for that is surveillance CT. Now, shared decision-making is another area that there have been several questions. Now, it does need to be performed by a licensed independent practitioner. So a physician, a nurse practitioner, a physician assistant, somebody who can bill. It can be done face-to-face or through telehealth. And that was one of the benefits that we found through the pandemic, that we did find that telehealth works for a lot of things, and particularly useful for the shared decision-making visit. It is required by Medicare for first-time screens only. It is optional in Medicare for the subsequent annual screens. It is reimbursed by Medicare for each annual screen if performed, but it is required the first time. And if a patient goes through shared decision-making and decides not to do lung cancer screening CT, that's okay. You can still bill for the shared decision-making. And maybe the patient will come back 2 or 3 months later and decide, hey, maybe I should consider that CT. And then you can bill for it again. So Medicare actually allows for it to be billed multiple times per year. And if it is done as part of an EM visit with a provider, it can be billed with a 25 modifier. Now, we've heard a little bit about smoking cessation intervention. And certainly this is recommended for current smokers. And it can be done as counseling. And if it's done as a separate counseling visit, then this has to be documented separately. And Medicare will actually reimburse for smoking cessation counseling up to 8 times per year. And this can be done as part of the ENM visit as well, with a 25 modifier. Another obviously adequate intervention for smoking cessation is referral of patients to Quitline. Medicare does require that a structured reporting system be used, and LungRads was created for this purpose. And we recommend that it be used for reporting the screening CT and also any interval follow-up chest CT so that we can continue to track the patient. It is required for participation in the ACR lung cancer screening registry. Now, submission of data to a CMS approved registry is required by CMS. As of right now, the ACR registry is the only CMS approved registry. Submission of data is required, though, for all screening exams, not just the Medicare patients. And this would include your self-pay patients and patients that are outside of the normal screening eligibility requirements. And there has been some discussion about when you get reports back on the registry that there will be some consideration if in fact you've reported on these other patients that are outside the eligibility criteria, but actually that data can be used like we are currently and have done now with dropping the age to 50 and 20 pack years. And we know that several of the patients that did not meet criteria previously now would. And then the ACR submits a subset of its data to CMS quarterly. Now, the eligibility for Medicare coverage is currently 55 to 77 years, 30 pack year history of smoking, current tobacco use or quit within the last 15 years, no signs or symptoms of lung cancer. And this can be interpreted in a lot of ways. My program and many places use hemoptysis or coughing up blood or unexplained weight loss as signs or symptoms of lung cancer. A cough is not a symptom of lung cancer in and of itself. Many patients have cough who have underlying obstructive disease. So it's really something that would be unusual for the patient, such as coughing up blood or unexplained weight loss. And then, as I mentioned earlier, the Medicare national coverage decision is now currently under review. I'm just delighted to tell you about Colorado Medicaid. I mentioned this earlier. They did adopt the new guidelines. So right now, individuals ages 50 to 80 are eligible with at least 20 pack year history of smoking, current tobacco use or quit within the last 15 years, and no signs or symptoms of lung cancer. And then the eligibility for commercial insurance coverage. Fortunately, with the Affordable Care Act, our commercial insurers had to align with the new 2021 task force recommendations. They have up to a year to a year and a half to do that. But again, the eligibility requirements are the 50 to 80 years, 20 pack years of smoking history, current tobacco use or quit within the last 15 years, and no signs or symptoms of lung cancer. Now, eligibility for self-pay, this is going to be up to each individual program for lung cancer screening. And many programs do find it beneficial to offer a self-pay option. Originally, many programs did this for the NCCN Group 2 criteria, which were the age 50 and 20 pack years plus one other risk factor. Now, many of those folks are going to be eligible now anyway, but we also can use it for patients who may be more than 15 years since quit or over age 80. Again, this is up to your individual program. these exams would not be reimbursable because they do not align with insurance coverage, Medicare or Medicaid coverage, but you may find in your program that it is reasonable and valuable to offer scans to patients who've been involved in your screening program, and now you'd have to either have them exit your program because they're more than 15 years since quit or they're over 80. Another approach is to use lung cancer risk calculators, and the Tamamagi calculator is quite common, and many programs use greater than a 1.3, 1.5, or 1.7% cutoff to allow patients to get screening CTs if they meet those criteria, and these would be self-based. Now, for pre-auth, it is not required for traditional Medicare. It is typically required by commercial insurance providers and some Medicare Advantage plans, and it is no longer required by Colorado Medicaid. And then for the billing and coding, the shared decision-making visit, if it is the G0296 that did not change. Recently, some other things changed, but this did not. And using this code, the patient should have no copay by Medicare. And of course, Medicare does require this. For the low-dose CT, the code you should be using now is the 71271. If you use that code, there should be no copay or cost sharing by the patient. This code did replace the G0297. You do have to include an ICD-10 code with your billing. And then for the interval CTs, since this is a diagnostic CT, you would not be using the screening code, and you need to use the standard CPT code of 71250 for the CT chest without contrast. There's a separate code if you're using contrast, but most commonly we use the 71250. And importantly, patients need to understand, and this should probably be discussed with them during their shared decision-making visit, is that follow-up CTs, these interval follow-ups, typically will require a copay. Now, if a lung cancer diagnosis is made, it is important that the patient be removed from screening. And so they just need to be removed from the list of patients that are sent reminders for screening, as that they are now in treatment, and a surveillance CT is now appropriate for those patients. And those patients would need to stay within surveillance until an appropriate post-treatment phase has been completed, and that's usually 5 years. One more thing I want to share, good news. On November 2nd, just a few days ago, CMS released final rules for the 2022 HOPS, that's the Hospital Outpatient Prospective Payment System, which reassigned the CPT code, our current screening CTP code of 71271, to the second tier APC. And this is a lot of abbreviations and language, but the important thing to note here is that instead of us talking commonly about lower rates of reimbursement and so forth, lung cancer screening actually got a boost. So the CT portion of the lung cancer screening is now reimbursed at $111.19, and that's an increase from $80.90, 37% increase. So that is good news, especially for anybody doing screening at the hospital outpatient level. So for more information, please feel free to go to the ACR website, and you can get this resource, this handout, by clicking this link. And so I've gone a little bit over. I apologize. And since I am the moderator for the panel discussion, we can go right into that. And I'm going to stop sharing and ask our panelists to make sure that they're front and center with us. And so I'm going to introduce our panelists. I got a message from Grant that somehow he lost connection. So Grant, Warren, who's the navigator at National Jewish, may not be back on just yet. Do we have Sharon Lundy? And we do have Bice. I see Bice. And there's Grant. Okay. And Sharon. And then we have Karen Wilson. And Karen is from Parker Adventist. And do we have Karen out there?
There we go. I got everyone.
Oh, good, good. Okay. Well, I am going to let everybody individually just describe a little bit about what they do in the lung cancer screening world. And then I am going to ask you all some specific questions. And then I just want you to give me your honest feedback. And, you know, you may have some dialogue amongst yourselves too. So Bice, do you want to start and just introduce where you work and what you do?
Sure. Thanks so much. And I appreciate you inviting me to be a part of this symposium. So my name is Bice Marsalek, and I'm a nurse. I'm an oncology nurse navigator through Sarah Cannon. My site is Swedish Medical Center, and I primarily navigate patients with thoracic or lung, GI, and complex GI cancers. And so I am also on the Lung Task Force Committee for the Colorado Cancer Coalition, and I'm also the chair for the Metro Denver chapter of Oncology Nursing Society.
Thank you.
Welcome.
Grant.
Hello, I'm Grant Warren. I am the lung cancer screening coordinator, patient navigator at National Jewish Health. So I am primarily responsible just for scheduling the patients, checking the eligibility, helping with some follow-up stuff. So yeah, that's my role in the lung cancer screening program here.
Thank you. Sharon.
I'm Sharon Lundy. I am the actually patient lung navigator at Lutheran. So I navigate patients, but I also run the lung screening program, the incidental lung nodule program, and assist with the lung health clinic. And I've been an oncology nurse for about 30 years and have been doing lung for about 11.
Thank you. And Karen.
Hi, I'm Karen. I'm the lung nurse navigator at Parker Adventist Hospital, and I do run the lung screenings and also the incidental lung nodule clinic.
Well, thank you. Thank you all for participating today. And I'm hoping that everybody that's on the call will be able to benefit by hearing from you all, considering your experience. And I wanted to start with talking about tracking patients and maybe some of the tools that you currently use to do that. And so I'm curious to know what works and what doesn't work. So maybe I'll tap Sharon first. Sharon, do you want to tell us about your experience?
Well, when we first started, 7 years ago, the good old Excel spreadsheet was our baby. And then as the numbers got higher, that was not doable. So we started working within Epic, which is our medical record at Lutheran, and figured out a process there. And then the numbers kept growing. And so then we got software, which has kind of saved our heinies. It's a very good, it's a lot of help when it comes to letters, tracking, and submitting data to the ACR. So we've kind of gone full blown. I still like paper. And so now our next goal is for me to get rid of paper. So that's what we're working on right now, is changing some processes to try to get rid of my beloved paper. So
I love it. That's very honest. And I hear that actually from a lot of people. And Karen, do you want to tell us, how do you track patients? And what tools do you use?
We use Epic. So I have 2 reports that I can run for incidental lung nodules. So, off of Fleischner, and they go onto an Excel spreadsheet. For lung screenings, we do everything within Epic. And so we run the reports, we have letters built in there. And so then I can just, hit print and a letter gets sent off to the patient with their lung screening findings.
And have you worked with anything that didn't work? What in your experience didn't work?
Epic didn't work until we worked with Epic, the Epic builders, and actually built a lot of this ourselves, because we were told, we couldn't buy anything else. So we needed to make Epic work.
Okay. All right. But you did. It sounds like you did make it work then. Very good. Bice, how about you?
Well, we use in the program that I'm involved in, I actually partner with the lung program coordinator, the lung nodule program coordinator, and we use 2 platforms. One is for tracking the lung nodules, and the other platform is a sort of a natural intelligence software that was designed that it sends a cue to me based on keywords. So after the lung nodule is followed, the patient is sent to the pulmonologist, and they go through the steps of being screened. So they use that kind of a program for the lung nodules. And then I have also an intelligence program that cues me in on which ones that I need to be aware of and track, so that I can, and I think I think within those programs, there's a database where they can, generate that information and data for whoever asks or when they're distributing it.
Oh, you're on mute, Debbie.
Excuse me, I was coughing. I'm going to ask Grant.
Take it away, Grant.
All right. At here at National Jewish, we primarily track our lung cancer screening patients via our EMR system. We don't work within Epic. We have all scripts. So we get our orders sent, and we kind of get notified through our in-basket. We also have internal reporting as well for upcoming interval CT follow-ups. So we kind of can keep track of patients who have those suspicious nodules who are needing follow-up care. We also work within REDCap as well to kind of follow those patients. But primarily, we track our patients through the EMR, at least for annual screening for sure.
Okay, thanks. I'm sorry, I'm losing my voice. So I am curious then, also kind of moving on, how you all manage referrals, and particularly those patients right now that don't have insurance coverage that would that have adopted the new guidelines. So if you've got the age 53 20-pack year, what do you say to that person if their insurance doesn't cover? And Sharon, I'll go back to you.
Okay. So we have created a self-pay program for the patients. So per legal, you have to submit the bill to their insurance if they have some sort of insurance. And if they refuse to pay, then it can be switched over to self-pay. Or if the patient doesn't have a insurance, then they can do a self-pay program so that they can be screened. Ours is about $260, which seems to be kind of the national standard average, which I think is pricey. For a lot of these folks, they're lower economic. So, but it's within standard norms. So, you just have to discuss it with the patient. If they have insurance, new guidelines, you know, usually don't find problems if they have any kind of insurance other than like catastrophic, that it'll cover the screening program. So I'll hand off to Vice.
I personally don't handle that part of it. I know that in part of our handling referrals, they're sent to, there's a process that when there's an incidental nodule found or a screening that according to the lung rads needs to be followed up, then they notify, I know the lung coordinator notifies the primary physician and the patient. And then the process of getting them in to see a pulmonologist is a part of that process. So in that process, I don't know if it's the primary physician that initiates that or the patient does that, you know, as they're scheduling the screening. But I know that with the new guidelines, the hospital and the different radiology clinics, I know that they have people who help with that kind of financing and education on what options are.
Thank you. And Grant, do you want to describe kind of what we're doing in this transition phase at National Jewish?
Yeah, kind of like how we're handling referrals and stuff. Well, yeah, we usually we get fax from the primary care physicians or different clinics, and that's how we kind of, and we reach out to the patients, and after their CT scans are done, we fax those reports as well. Sometimes we get them like just faxed through our fax machine. Others are sent through electronically through Epic. We do have a self-pay option that helps with giving patients who aren't necessarily eligible to be covered by insurance to have an option to have their lung cancer screening. But like Sharon said, it is expensive. It's $250 for our self-pay. You know, what we try to do here at National Jewish, we do have a good partnership currently with the Bruner and Caritas clinics that are helping get those uninsured patients in for lung cancer screening, and networking with those different clinics who are able to provide those kind of screening exams and provide our services to them who may not have been eligible without them. So, yeah.
Thanks. Yeah. Karen, how are you guys approaching those patients that may be sort of in transition?
Well, we do have a self-pay. I want to say it's $99, but nobody takes us up on it.
Oh,
because in the month of November, we do them for free.
whoa.
So anyone who wants one gets one for free. So I can do anyone that's outside the guidelines, but they might have a risk for it. And we do firefighters. So we do, last year we did 250 free ones. And so far we've done 50 so far this month.
That is really cool. I haven't heard about this kind of an approach. And that's just, and within that firefighter group, how do you contact them? How do you let them know? And is it firefighters all over town or just in your immediate community?
Nope, we do 80 firefighter in the state of Colorado, and we have our whatever, is he a paramedic educator, whatever he does in the hospital. So he just puts words out to all the fire departments in the state of Colorado that we are offering this. And then our trauma surgeon signs the orders for the firefighters. And then any PCP can put an order in for anybody else.
That is very interesting. Has anybody else contemplated something like this? Yeah, I mean, that's really a novel approach. And is the expectation that they're going to come back for annuals?
Yes, in fact, I've got 3 I know so far, firefighters that have come back.
And you said if they don't qualify, you still
We
screen
still
them?
do it. Because,
So
you know,
how do they
actually,
come back?
they just contact me.
And so they're done free again next year?
Yep.
Wow.
Yeah,
I like that.
our foundation picks up the bill for that, which surprised me. My boss actually set that up. And then after I'd gone to a Go-To Foundation conference, and UC Health was saying they had a grant for this, I went and approached my boss and said, can we do people that fall outside? Thinking I would get some vapors or something, but nope, haven't gotten any of those yet. And I say, can I do firefighters? And so that was absolutely.
Wow. Well, this
That's
is a
amazing.
wonderful, that is a really terrific approach. I was going to ask you all about your community outreach. Have you all done any other kind of, I don't know, health fairs or any other particular outreach to the community to try to educate and bring folks in?
We had done the 9 health fairs, you know, prior to COVID. We had done that.
Yeah, we used to do them too.
I did too.
Well, I know, Sharon, you've done something because I spoke at one of yours when you guys did a health fair in your parking lot. Remember that?
We've done, we do stuff with Cancer Survivors Day. We do things in the hospital for like during the month of November and we team with like respiratory therapy, and they do PFTs for folks. We go to doctor's office with our physician liaison and talk to them. Anything and anywhere. Somebody will talk to me, I'll talk to them.
Yeah. And I actually go in our cafeteria and have a little table in the month of November, and I have blue candy
Nice.
ahead out.
Yep.
Yeah.
We have cold turkey sandwiches in the cafeteria to quit cold turkey.
Oh,
That's great.
seriously? You do that?
Yep.
Oh
We
my
put
gosh.
a white light,
Awesome.
a white ribbon on the side of the hospital for the month of November, a light that shines at night.
Oh, nice.
Yeah.
Excellent. I am wondering if anybody in the audience has any questions for our panel. And one question that has come in is with your self-pay, does that include both the technical and the professional charge? Because the radiologist does have to read the CT, and sometimes it's a global bill and sometimes it's not. Ours at National Jewish is a global for $250. That's the technical and the pro together. Do you know, Sharon, about yours?
I know that it's a $199 and a $60. So
Oh.
I'm assuming it's both. It just is, the total is the $260.
Okay.
So I would say it was both.
And Karen, how about yours?
Yeah, our
The free.
radiologists do that. Yep. Our radiologists throw in their fee in November, and they're included in the cash one too. But everyone just
Okay.
waits till November.
That would be an interesting approach for radiologists to engage in the community that way. I don't know that anybody's quite thought of it. Bice, do you have any idea if you guys have done anything like this?
Well, I know that they do a lot of, they've done community outreach where they've had the marketing puts out some collateral just to engage the community in taking care of themselves. I think they're about to launch something in our hospital in the near future. Like in the next, I don't know if it's the next week. I have to check and see. I haven't been privy to that yet. So I don't know how I'm going to participate in it this month. But yeah, they do a lot of physician engagement, and our physician liaisons. They also go and visit. The lung nodule coordinator goes to a lot of the clinics. I know that some of our partner physicians with the lung program at Swedish have done some workshops, some mini workshops, and they're hoping to continue that so that the primary physicians also see the work that's being done, and, to get the awareness and see how they can participate. So I think that's, unfortunately, I don't work in that part of it. So unfortunately, I don't get all that information right away, but I'm hoping to find out what the program is in the next week.
Well, good. One of the things that we just did, Grant mentioned at National Jewish, at the main campus, we have Allscripts is our EMR, and we're able to query and figure out, how many or which patients would theoretically be eligible for lung cancer screening based on the old criteria and the new criteria. And so we did a query, and we had found that even looking at with the old criteria, we were only scanning about 25% of the eligible patients. And then with the new criteria, it's about 15 or 16%. So we are planning to get that word out to our staff in the next week or so by just visiting some of their division meetings and saying, did you know there's a lot of people out there that now they may not be eligible for other reasons, right? Just because they meet the age or the smoking history, that's kind of what the EMR can tell you. And there may be a lot of other reasons that they wouldn't be appropriate for screening, but it certainly is useful to try to have a starting place like that and to use the resources. I think many folks talk about how our EMRs just need to help us more, whether they can give us alerts, best practice alerts, or flag when a patient's overdue or whatever. But one of the things that we found we could do was at least find out, we're not reaching everybody that we could. Have you guys tried anything like that?
So we just went live with my chart, flagging everyone that potentially could qualify for lung screening. So it comes up when the physician sees the patient. So for the Front Range, I think it's flagged about 16,000 people. So I guess I have my work cut out for me.
Wow.
So, be careful what you ask for. It's exciting, but haven't quite yet figured out how to follow up on that.
Mm-hmm.
So.
All right, but it's a starting place. Clearly.
Yeah.
Let's see. So I'm curious. I'm looking in the chat here. Actually, there's a couple comments from Jamie at the university, and we don't have anybody from the university on the panel. And I wonder if Jamie or Aaron knows if the university is doing any kind of queries of the EMR like this.
Debbie, I don't know if they are or not at this point, but I can check with Dr. Nina Thomas, who is directing our program, and see what they're, how they're managing to kind of call the eligible community and identify them the opportunity.
I was going to say, Siller, I don't know, Debbie, but we can.
But if you have a unifying EMR like you do, it is kind of a helpful tool. As far as going back to kind of the whole community outreach thing, has anybody ever tried to engage folks like community leaders, like on your local city council, or somebody in the community that's just really that you might know, even almost like celebrity professional athlete status, to see if they might help be a spokesperson? I'm guessing that might help, but I've never tried that. Has anybody, even up in our attendees today, had any experience with that sort of thing?
We did back in Kentucky. We would commonly invite mayors and things to some of our outreach events to build community awareness and some endorsement. We did have, for those of you who are familiar with Kentucky basketball, it's kind of important there. And we had a player who's one of their parents had been diagnosed with lung cancer. And indeed, Coach Calipari's mother had been diagnosed with lung cancer. And so there was some effort to outreach to Coach Cal, but he's a little bit preoccupied with other issues. But we did get the player involved in some of our walks to raise awareness and things like that, and was a little bit productive there.
I would think the university would, with their, work with you, with the Broncos and the UC Health Training Center.
Oh, that's a really good idea. Yeah.
Yeah, I know the NFL's doing the cancer initiative this season. So that would be a really great idea, is to contact them. And
well, we have Allie Bain. Maybe she can tell us more about the ACS NFL Initiative.
Yeah, so every October, the NFL raises funds that go directly to ACS that are then granted back out to communities through our Crucial Catch Change Grant program. So we're actually just finishing up a lung cancer change grant with Brunner and Caritas, part of the St. Joseph system and National Jewish. So we are seeing the NFL get more involved in the lung cancer screening space. Initially, they were just interested in breast and colorectal, but now we're seeing lung cancer screening be more of a priority too. And earlier, Erin had mentioned that we were talking about some grant availability in our breakout group, and some of that funding is coming directly from the NFL. So certainly that money is going to ACS, and we are trying to grant that back out to help increase lung cancer screening.
Yeah, that's terrific. How did that happen? Do you know? The initial alliance with the NFL?
That's a good question. I don't exactly know the history of it. I know that it started out as just breast cancer, and the Broncos were actually the first team to expand it to all cancers. So the Broncos started their Fight Like a Bronco campaign after one of their turf managers was diagnosed with colorectal cancer in his 30s. And after that, the rest of the NFL and the rest of the NFL teams and the NFL in general increased their program to be all cancers. So the Broncos definitely did have a stake in that. And then the Broncos do actually donate money to ACS here in Colorado for breast and colorectal screening. So there's certainly be an opportunity to expand that to lung as well in the future.
There was an NFL player, I think Jamie said, was it Chris
Draft?
Yeah. My husband will kill me because I have no idea, but I think Go-To Foundation, he might have presented at once or talked at once, but it was a family member that had lung cancer, maybe someone really close to him.
Chris Draft is a NFL player. He has played it with several teams, and it was his girlfriend at the time that was diagnosed, and they eventually got married not too long before her life ended due to lung cancer. But Chris has endless energy to rally the lung cancer community together, and he has the Chris Draft Family Foundation, which is pretty much entirely committed to supporting survivors and the lung cancer community overall in terms of reducing the lung cancer burden. And a lot of his work is on lung cancer screening, but some on stigma and some on survivorship. But he's a Stanford grad and is really engaged with the NFL leadership, and has levers that I'll never be able to pull in terms of organizations at that structure, as well as I'll probably never have half the energy that he exerts in a single day on this topic. So it's he really is a fantastic advocate and someone that passes through Colorado quite a bit. He's really involved with the White Ribbon project that Heidi and Pierre, I got mine here too, Debbie. Heidi and Pierre Onda have led, and I don't know if Heidi and Pierre are on today, but they might be able to say more things about Chris. But Chris is in it for the long haul. He's been involved with the National Lung Cancer Roundtable for quite a while, and has lots of ideas.
Yeah, I was able to meet him at a White Ribbon event just in October, just a few weeks ago at Heidi's house. And Heidi will be on next Friday and share her story and thoughts. I'm also wondering if, and I'm picking on you here, and Deb, you may not know, but Deb Ritzwaller's on from Kaiser. And I know certainly even through our all-payer claims database, we know that Kaiser, for many years had been like the #1 volume screener in Colorado. And Deb, do you know strategies that Kaiser has used to just get patients in for screening?
Thanks, Debbie. And I was just about to post great job to all speakers in the panel today. This has really been really a lot of fun and great info to see. So I do want to say two things. We began in 2014 with a semi-centralized program, not too perfect. We didn't screen. We screened a fair number of folks who were not eligible, about half, misuse of code or whatever. So then in 2015, we started a centralized program with about 6 key staff, and we enhanced our IT program. So I think the key piece we have is that we pull from the EHR data, at least the age category, the age eligibility, and whether or not they're smokers or former smokers. And that shows up on the desktop in the electronic medical record as a care gap when the provider opens the patient's record. So, for example, where we got the biggest bang for our buck was at wellness visits, annual wellness visits. That would show up, and that's to our understanding what initiated the first conversation. Then from there would be a referral to our program, follow-up with eligibility confirmation, assistance with scheduling, and then automated follow-up with both reports if it was a negative screen, LRADS 1 or 2, but still additional details around, especially LRADS 2, and then automatic reminders for when the patient was due for either their interval scan if there was a positive screen or for their annual. So I think that's where we really made a difference early on. However, and of note, and I don't know if Kyla's on or has been on, but can also address this, given that we have a medical home model, we have shifted this model during COVID back to every economist's dream, a really fabulous double whammy natural experiment, back to the primary care clinics. We still have the Navigator piece, and we still have the care gap pieces that alert. But I think the navigation has been, and I think this has been addressed by this panel, has been key.
Yeah. Wow, I like that term, care gap. That really sort of hits the nail on the head there.
So it's kind of like the commercial where we see on the breast cancer screening stuff. It's the same idea. So whether it's breast cancer, colorectal, lung, cervical, if there's something that you haven't, if the patient has not been caught up in. So that's why we try to couch lung cancer screening kind of into the same sort of category as the others. So I think Jamie and Aaron's issues around whether it's stigma or other, that this is lung cancer. So it's a care gap, just like you're due for your FIT or your colonoscopy.
Well, we can certainly learn from our experiences in the breast cancer screening world and the colon cancer screening world. We don't have to reinvent the wheel. And the other thing we've learned too, and maybe some of you have tried this, is we can collaborate with our breast cancer screening centers. There's been some studies that have shown that if women who come in for breast cancer screenings, mammograms, they've already bought into the idea of screening. So it's not too hard to convince them that, maybe if they're eligible for lung cancer screening, they should do that too, or maybe even a family member. So I don't know if any of you have tried that approach, but there on a national level, I know it's been successful at several places, and it's really recommended that we try to join forces with some of our colleagues in doing breast cancer screening in your own institution. So any other thoughts, comments from the audience? Well, I thank our panelists. Thank you so much for volunteering to share your thoughts with us today, and for those who commented also in our attendees. And I am going to, maybe we can wrap up a little early today, but I'm delighted to hand everything now off to Morgan. And Morgan Shan is another member of our lung cancer task force. And she's actually co-chair with Jim Fenton, Tim Kennedy, and I. And Morgan's going to give us kind of a wrap up of today. And it's really fun having Morgan work with us. Many of you may know that Morgan actually lives in New York, but she's got her heart in Colorado because she works so well with us on our lung cancer task force. And she's also helping to launch a sort of a lung cancer coalition in Maryland. So you might share a little bit of that, Morgan, in your closing. So thank you.
Thank you so much, Debbie, for that warm welcome. And thank you to all the attendees today. I know that it's hard to do a half-day session like this on a Friday, but don't get me wrong, definitely happy to be here. But yeah, to echo what Debbie was speaking on just now, we are in the process. I really am passionate about state-run initiatives. I do think that that's kind of the boots on the ground for a lot of these programs, and it's really important to understand what's going on at the state level. And you'll see what I've noticed talking to several states now is that a lot of states kind of have the same problems when it comes to lung cancer screening. So it's really useful to see one state and see some of the strategies they might use for a certain situation and be able to apply them to another state, or see that things are a little bit different for this population, et cetera. So after working with Colorado for Debbie, I think I'm going on 3 years now. I think this February will be 3 years. I wanted to expand and learn more about other states and what they're doing. So we're doing that right now with the state of Maryland. And we're also doing that with the state of New York. That's another collaborative, or they call them action teams up here that we're working on. So with that said, next slide, please. This comes back to what we spoke about today. And opened with, in a state where 23 people a day die from cancer, and in a state where cancer is the leading cause of death, and in a state where lung cancer is the leading cause of death, or excuse me, lung cancer is the leading cancer. How do we work together to prevent cancer, find it earlier, treat it better, and improve the quality of life for survivors? And like Christy said, I just want to reiterate that you all here are a big piece of that puzzle. We tried to do this last year and we were successful, and I think we've been successful with this as well, in that we've really tried to reach across the lung cancer screening care continuum. And we've tried to engage providers as well as nurse navigators, academics, patient advocates, and the patient perspective. All of that is really important for addressing such a multifaceted issue like lung cancer screening. So I'm very happy and pleased to see that we had a breadth of different perspectives and opinions and areas of expertise here today. These are some other ways to get involved. Oh, if you could go back, please, Christy, I'm sorry. If you aren't a member of the Colorado Cancer Coalition Lung Cancer Task Force, highly recommend for you to join. You can contact myself or Christy for more info on membership. It's a fairly well-knit group, pretty collegial, and we all get along, and we'd be happy to have anyone's perspective or interest in the task force. We meet on the third Tuesday of every month at 5:30 p.m. Mountain Time. So yeah, we certainly encourage you to join, and we're always looking for new members. Another thing that you could look into is if you're a site or a facility that's looking to start a more formal lung cancer screening program, the ACR does have a toolkit available that just helps give you basic instruction on how to set up a program, what kind of people you're going to need to get involved, how you should track patients, and some other resources. So the ACR has been great on that. And then I wanted to, another thing you could do too is the Quitline. I don't believe we're talking about this today. It might be on the agenda, I think, for next week, I want to say. But one part, I think it speaks to the idea that we could screen and scan all we want, but if we're not working on tobacco cessation as well, we're just perpetuating this cycle of lung cancer. So tobacco cessation is a huge part of lung cancer screening, not just from early detection, but just overall preventative, and it's just good for your health. I think we all know that, and reaching that population is something that we're still working on here in Colorado. So with that, next slide, please. I also want to take a moment to thank the University of Colorado again for their participation and support. And I'd like to also thank AstraZeneca. So with that said too, join us next week. We have another session on November 12th. The networking we have through the Gatherly app is about 1 hour. So that starts around 12, and folks can come in and drop in and leave as they please. And then the symposium formally starts at 1 p.m. Mountain Time, and we look forward to seeing you all.
I just want to pipe in a little bit about the Gatherly session. We did get a Gatherly networking today between the mini symposium and this. And so we had some of you from here and some from the mini symposium attend. And I heard pretty positive reviews of using that as a virtual networking tool right now in this virtual world that we find ourselves in. So next week, we'll plan to have all lung cancer specific tables. So we'll have a radon work group table, a lung cancer screening work group table. I'll be at a table, and you can just come learn more about the coalition in general. So please do come to that networking time. It is really meant to, since we couldn't do this in person, you can see who's in there and you can go chat with them, just like you're networking in real life and looking for someone in a hallway or in a networking hall. Don't even know what those are called anymore. So please come at 12 next Friday for that, because it's a really fun way to engage right now. And I want to thank the Lung Cancer Task Force for putting together this amazing collaborative full of great content. So thank you all for your hard work in putting this together and finding excellent speakers. And the examples and success stories that were shared today, this is exactly why the coalition exists, to have these conversations so that you can share those best practices and people can learn from them and start to think about how they can do that within their own organization. So thank you for sharing all those ideas in the panel.
Thank you. And thanks, Christy, for helping organize everything for us. I promise next week I'll have my voice back. Please do fill out the evaluation. I do hope you'll join us next week. And I look forward to someday being in a room with all of you, really, for real.
One day we'll get to sit at real tables and have those conversations in person.
All right. Thanks so much.
Thank you, everyone. Have a good
Thanks,
weekend.
everybody.
Bye.